Asia is really a geographic construct, and Asia spans the entire gamut from very, very poorly resourced countries to much more affluent ones with challenges ranging from malnutrition, both under as well as over, that's the so-called double scourge of both the chronic as well as the infectious diseases. So what can precision public health do for us here in the Asia Pacific?
The previous CEO of the Gates Foundation, Sue Desmond-Hellmann, had really touted this as a revolutionary change within the work that we were doing in LMICs. And in 2016, she had an editorial in Science that focused on the potential impact of precision population health and ended that piece with this quote, that we have the tools to bring the right interventions to the right people in the right places to save lives. Now we just need the will. And I think we're really now faced with this question that Sue ended with in her editorial 5 years ago. Do we have the will to act? And this idea of innovation, bringing the present closer to the future, is really the area that I would like to pose for our panel and that we are continuing to struggle with within the foundation.
Who pays and how much? There are actually three options for the lower and middle income countries. You know, honestly, I believe that the best strategy for us is for government to fund precision medicine, public health, precision public health, the efforts, as well as digital technology. Of course, you know, we can have a public-private partnership in the local setting. Foreign support is okay, but if it cannot be sustained in a local setting, it is not really sustainable. Now, a third one, a creative and very feasible option is for a high-income country to share the tools, the technology with the low and middle-income countries. So I just want to share with you two short anecdotes. On a personal note, I want to share that the Children's Hospital in Sydney, originally the Royal Alexandra Hospital for Children in Camperdown, during my training 3 decades ago, helped me set up my genetic services in the Philippines. That made a difference in jump-starting the services in my country. A more recent example is when the Genome Institute of Singapore, then under Dr. Edison Liu, guided me in setting up the Philippine Genome Center in 2009. So the big brother, small brother concept does work. Now, who benefits? If the government pays and works for integration in the public health system, then everybody in the economic strata will benefit. When there is a cost, the delivery of service is limited to a sector of society and primarily to those who can pay. Now, who suffers if not equitably delivered? Definitely, if there is a fee, the poor, the marginalized, and the elderly will suffer. Now, who profits? You know, I believe that if equitably provided, the gains will be indirect to the government and direct to the people because we offer better health. From the perspective of precision medicine as applied to the public health, I agree that there is a need for complicated data systems that can integrate genomic information into clinical data. And the COVID-19 situation has shown the critical role of digital tools. So now allow me to present some challenges for the low and middle income countries. Well, first, despite an appreciation that technology is critical for the delivery of services, low and middle income countries cannot readily avail. Technology will be assessed as expensive, and there will be other health priorities that need greater attention. So it is tough competition. Now, second, in the low and middle income countries, keeping local talent is a challenge. And from experience, even if we have a good number of young programmers, bioinformatics specialists, modelers, molecular biologists, we lose them to other countries with better paying jobs. And there must be a conscious and aggressive effort to train more and keep them in the country, and government must step in. And it's the same story with our doctors and our nurses.
And the other thing that is common is the essentials of the public health response, which have to be delivered wherever you are, you know, whether that's public education or contact tracing or quarantine or whatever it is, or case management, the essentials have to be delivered. And what I would say is when we went around the country we had to make sure that we weren't just applying technology for technology's sake. And our tech guru, Lee Jasper, was particularly keen that that not be the case. So you had to say, how does technology add value compared to the current response? The current response led by people with maybe non-technological, expertise, but a good, strong public health response. And then how could technology add value? And some of the best innovations came out of the states and territories with the least resources. And I think that's one of the messages, is that having not a lot of resources can drive a really strong discussion about priorities. And it can actually mean that you use technology smarter. And a lot of our technology innovation comes from trying to have good low tech, if you like, widely used. We often make this distinction between high tech and low tech, but high tech isn't glittery, high, machines. It's high value technology, and high value technology can be low tech technology, which is widely used and cheap and can be scaled up and can be used robustly in rural areas, for example, rather than just in cities.
It was interesting to hear Carmen's presentation, where she actually said two separate things. One is that there is a manpower problem, and she phrased it in terms of brain drain, but that's a lucky problem to have. Most of these countries actually don't even have the brain to be drained in the first place. There's no training. There's very few people who've taken that sort of course of education. But then the other thing is, she said that foreign support is unsustainable, and that is ultimately true. So one has to balance the need to supply know-how, which essentially must come from outside, versus the need to be self-sustainable in the future. And I mean that must come in the long run through education, through development of the manpower. But in the short term, the way to transition, because there is a risk that this gap will in fact widen rather than close over the next few years. So over the short term, what can we do? And this ties up, I think, to the role of the international bodies that are participating in this. I can tell you what we are doing, which is we've actually identified certain areas that are particularly hard for these endemic countries to implement, and these have to do with data processing and analysis and producing results that are translatable to the control programs. And what we have done is essentially we are creating a sort of consortial model whereby we supply the informatics power, but we actually are right now transitioning the laboratory operations to the countries, such that we can do sample processing within countries, and then data can be uploaded. And as long as we've agreed on common formats, then the information basically comes out in a semi-automated way. It's still very important to have local expertise in order to talk to the control programs, to interpret the data, and so on. And I would say, finally, all this is based on networks of trust. The control program doesn't really care whether you come from University of Oxford or University of whatever. They don't know whether to trust you, and it's important to have local scientists that can communicate with them, that can vouch for you, that can support the whole program. We found this to be invaluable, and until we develop the local expertise, this will remain a major problem.
ASEAN, in my opinion, is actually in a great position to actually be a world leader. There are definitely challenges, but ASEAN, because of the relatively low spend compared to other developed areas in the world, means that they start from a position where they don't already have the bloat and solving some of these problems. And that's huge. They can do it more efficiently. Also, because of the relatively small geographies that we're talking about, and the diversity in the reimbursement systems, that bias that I talked about before around the economics and the reimbursements and the data, that doesn't exist the same in ASEAN, because each country has its own reimbursement system and nuances. So that can't be the common denominator when it comes to healthcare data and sharing data and being collaborative. There has to be a different collaboration. And so I'm actually very excited to be working in the ASEAN region, because there are so much potential. Yes, there's hurdles, but there's so much potential in this region and we talk about the role of academia. There's potential for applying, somewhat like has been done with GIS, network theory, percolation theory, some of those theories that have yet to come in full force to healthcare. And ASEAN has the intellectual capital to do that. It's just fantastic where ASEAN is poised, in my opinion, to actually leapfrog much of what has been done in other countries that have unfortunately spent money and created systems that are not as effective, but now they're entrenched. And ASEAN doesn't have to do that.
Now, low and middle income countries, we've heard it even in the plenary this morning, they need a roster of creative and innovative ideas to hurdle the challenges. Now, these ideas can either be copied from another country or it can be something new, but it must be applicable to the setting of the country. And we need a cadre of professionals or experts to review the options, because these recommended innovative ideas will need the buy-in and support of government for precision medicine, precision public health, or even digital technology to deliver a more efficient, equitable, and better health. My personal take is that if precision medicine is not shared with the general public, then we are not implementing precision public health.